It's always good to be back in San Antonio. I grew up here, my folks still live here, and seeing all the friendly faces. It's been about 10 years since I left immunization program in San Antonio, and it was great. We did so many great things down here. We still do great things as a public health department, and I've been up at Austin for 10 years now with the CDC. And really what we're going to go over today is kind of give you an update that kind of feeds off Dr. Lakey's presentations and Brock Lamont's presentations on the VFC program in Texas. So we met with the local health departments 2 or 3 weeks ago and covered some of the issues, what the VFC program is, the populations, look at that, 2014 VFC program and 2015, what we think that's going to look like. So going to cover that. I also want to go over the population estimates a little bit. Dr. Lakey had talked about VFC eligibility, and Brock had hit about, in most of the states, about half the population is VFC. So we have those numbers in here as well. There's some extra resource slides that are in here, so we won't spend a lot of time on that due to the 40 minutes that we're going to go through the session. And then Vivian's also going to hit on a lot of stuff with the MTRAC 2 and the updates. So hopefully when we get this all posted online, if you have some more questions, certainly your regional immunization managers are a great resource, as well as your local health departments. So let's take off. Again, I do not have any relevant conflicts of interest or disclosures. Again, 20 years in the VFC program. So when I came to San Antonio, I started in the year that the VFC program was launched in 1994. And I know we saw this slide, and I think this slide should be in every presentation that we see out there about talking about the great benefits of the VFC program. I know Brock hit on it, and Dr. Lakey hit on it as well about, preventing disease, getting vaccines, making them available, and getting them to the provider. But what it really comes down to is the VFC program is an entitlement program to the child. So of all the things that we're working on in our partnerships and our contracts and our local health departments and our providers join the program, at the end of the day, it all goes back to the child. The child is the one who has access to the program. And what we need to do is do everything we can to remove the barriers and make sure that we can get the vaccines to the providers and they get the vaccines to the children. However we do that, and there's so many innovative ways, and Brock talked to that as well about what we're doing in Texas about trying to get and leverage all of our resources to get vaccines to the VFC eligible children. So that's one thing we need to remember. So of all the challenges that we have in our programs in our daily worlds, at the end of the day, it goes back to the child and making sure that they're ACIP vaccinated age appropriately. So 1994 to 2004. So when we were here back in 94, it was about 95% of the immunizations that were given in public health departments. We had 22 clinics, I think, that were under the health department. I think now we have 2 or 3. So the public infrastructure was very important to make sure that vaccines were made available. We were on the phone taking orders. People would come pick up vaccines in coolers. There wasn't a lot of guidance on storage and handling. There wasn't a computer automated system to track anything. I mean, we didn't have spreadsheets. We were with highlighters and big chief notebooks and trying to figure out where all these doses are going. And we would drive them out of a big cooler that we had stored at the main office, and providers would either come pick them up, and there wasn't, they'd put them on a block of ice, maybe, have that little piece of paper in between them as their vaccine storage and handling guidelines. And as all y'all know, that has certainly changed since 1994 in many ways, and we're excited for that. Tracking again and documentation. You try to find shot records from 20 years ago. You might have a stamp, you might have a name, probably don't have a lot number, probably don't have a manufacturer. There weren't a lot of vaccines being as part of the program in 1994 as well, so maybe you'd see 3 or 4 different immunizations listed at the beginning of the VFC program. So here we are today. Certainly the vaccine delivery system has changed. As a state agency and working with the CDC, we can turn around and get vaccines to providers, within a day. We can get it there within hours now if we have an outbreak situation. What also we can do is we can move vaccines. So if we know that, we have hurricanes hitting all the time, September, October, we can get vaccines mobilized and get them out of areas that may be at risk. We wouldn't have been able to do any of that, 20 years ago. Active responses, VPD outbreaks. We have an automated vaccine ordering system. Again, like in the old days, it was on a phone and a fax, and you could kind of see the orders coming through, but through a fax machine 20 years ago, it was tough. Everything's automated in tracking. We have an immunization information system now, way more advanced than what it was 20 years ago. Billing systems, EMR systems. Again, we've talked about storage and handling, and that was Brock's major point in coming down here, is really re-emphasizing all the different vaccine storage and handling protocols, policies, procedures that have come out, really to go back and protect the vaccines and start asking the questions. It's not just VFC, it's the private stocks as well. Are these vaccines maintained correctly? Are they transported correctly? And are they given to the children correctly? And all of the emphasis that our VFC program has really looked at over the last 2 years has focused on vaccine storage and handling. Certainly, there were a lot of recommendations as well. There weren't school and daycare requirements 20 years ago. So, immunization coverage levels really weren't looked at as they are now. And now every time in, October, November, you start seeing those immunization coverage levels. There's different antigens, there's uptake, there's behind schedules, there's makeup schedules, there's public versus private kids. So it's come a long way in the last 20 years in regards to what the CDC and what the states and locals have done as expansion of the VFC program. So, want to kind of really look at this. This is where it was in 1994. 7 vaccines. That's all we had to monitor. That's all we had to look at. They weren't coming in for multiple visits, multiple times. It was pretty easy to keep up with the immunization schedules then. As soon as the next year came, we added 3 more vaccines to the immunization schedule. The 1994 one, again, was fairly simple. You were done with vaccinating children by the time they were in school. It wasn't an adolescent program, very little on adult. Flu was not a big player like it is now. There certainly weren't universal recommendations for that. 2001 came and we were able to add hepatitis and pneumococcal conjugate. 2006 came and we started really looking at doing adolescent vaccines with meningococcal, and rotavirus was added to the schedule. 2011 and into now, we have 16 vaccines with the addition of HPV. Now, certainly it's not just adding vaccines, it's changing the schedules over the years. I mean, there used to be 2 doses and it was 3, then some were 4, then some were back to 2. So it's certainly very complicated. And this is just a snapshot of the schedule now, which I know you guys are all familiar with. But there's, like Dr. Atkinson was talking about, there's makeup schedules and 4 days before and 4 days after, and what do you do and when do you call them back? And it's certainly complicated. And, we're working on continuing to get our training resources up, as is the CDC, about when you come back and get vaccines, what age appropriate. There's 3 or 4 different products now in a lot of cases for different products, so it's certainly a challenging world out there. Let's see this. So, 19 shots or drops at the time, as compared to 55 now. So these are individual vaccines that are given over the course of 0 through 18 years of age. So it's overwhelming, and then we're building reminder recall systems to help bring these kids back in over and over again, and we've tried to advance it. But it really comes back to making sure that we're documenting and making sure these shot records are captured, paper copies, making it into the registry to make sure that we're age appropriate and we're not over vaccinating. And that's one of the major issues that we had in the early days when these vaccines started coming on board. They weren't really tracked. Parents would lose records. It was always told to age appropriate vaccinating. So we had kids 3 and 4 and 5 and up to 8 MMRs. I mean, it was crazy. So, because they didn't know. They didn't bring a schedule in, and they had to get to school, and they lost it, and we never had it. We had filing cabinets with paper records in them. So, again, we've come a long way with that, but, and Vivian's going to hit on this as well, is getting those records into the system is what's critical, and MTRAC is our state system that will do that for us. So, Brock had talked about this as well, the cost. Now, I only want to hit on vaccine financing a little bit, but, it was $155 to take care of a child back in '94, and now it takes, it'll be probably over $2,000 to vaccinate a full series going into next year with the new recommendations. The second dose meningococcal will be catching up now if a new product comes out and the price changes. So certainly a big challenge, a huge economic challenge for our program. And what's interesting about this slide is that this breaks up that cost between pediatrics and the adolescent population. So that second column, the $625, that never existed in the past because we didn't have adolescent vaccines. So since they've been added, 2/3 of the vaccine price is going in to take care of the pediatric population, and then the other third is taking care of the adolescents. So I have a couple extra slides on the population estimates, which you guys can go look back at your own time. But I really wanted to show you the major change that happened. And LJ had talked about this yesterday in his presentation about the population in Texas. So he was right. We have the highest uninsured population for 0 to 18 in the country as far as percent. But what's changed between 2014 is that the underinsured population has really decreased, which is hopefully part of the ACA and getting private insurances to pick up those vaccines that they weren't covering in the past. So in Texas, what we do is we allow private providers to vaccinate the underinsured. So we put resources, they're not part of the VFC program unless they're in the delegated clinics. So underinsured children who are accessing their private providers and getting vaccines through there, we cover that as a state expense, and we still do. That expense, $30, $40 million a year, it's been whittled down a bit because now private insurance is stepping up a little bit more and taking care of all those vaccines. You know, they have ACIP, first dollar coverage, all those terms about making sure that insurance plans step up. They're doing their jobs in that in Texas, but we still have, you know, 100,000 children, mainly adolescents, who are underinsured still in Texas, and that's what we need to work on, getting the insurance plans to cover them across the board. So breaking down 2015 in a little more details, you know, the average is about 48 to 50% of the children across the country is VFC eligible. And for us, we're about 55. So we're a little bit higher. That's because we have a high uninsured population. The rest of the population breaks out into CHIP program. In Texas, we do cover the CHIP children as well, as long as they're vaccinated in a provider's office who will build the CHIP program back. So CHIP gives us funds to take care of about 500,000 children a year, which is great. It's an expansion of our VFC program into the Texas part. And then we also take care of that underinsured population that I talked about. So when you look at it as far as the public health program in Texas, we take care of the VFC kids, we take care of the CHIP kids, and we take care of the underinsured kids. That's all part of our program. Last year, that was about 80% of all kids, 0 through 18. Now that the private insurance is starting to cover more of those vaccines that were underinsured, and a lot of that was mainly adolescent vaccines, you know, we're about 60, 65% now of the population. Which is good. I mean, that's what we're trying to get folks, our systems in Texas, to be accountable for taking care of our children. So we'll go through these real quickly. This just really looks at breaking down our populations. 37% of the Texas children 0 to 18 are on Medicaid. We have a small Asian American, Alaskan Native population. Again, we have the 16% without insurance, and that is our biggest challenge now, is, you know, getting them access to care, making sure that the public health infrastructure is there to take care of the uninsured. It's not a huge price point for private providers to be taking care of our uninsured populations, which is why we need to do whatever we can to keep our public health infrastructure network set up and stronger. And that's tough because, you know, as Brock pointed out, huge reductions in local health and regional health and DSHS resources as far as hiring people and getting folks out there to give shots. So on one side, we're trying to get private providers on board and get them to join the VFC program. And then on the other side, we're trying to keep that structure as strong as we can. But then we know that public health still has a huge immunization importance in the state. So again, we've talked about the different breakdowns in the populations. And you guys will have these slides, so you can kind of look at these in more detail. VFC, when you're just looking at the VFC kids, again, Medicaid makes up 66% of just the pocket of kids that are VFC. There's that no insurance again. So 30% of our public kids in the VFC program have no health insurance that covers immunizations. And then we talked about this as well. So the underinsured kids and the CHIP kids, they are covered through partnerships with those programs using state dollars. So the federal VFC program, this is where I think it's most confusing, is that when they say VFC in Texas, you know, and prior to 2012, VFC in Texas was, a lot of cases, everybody. We didn't have rules about if you were insured or not insured, whether you could access services. Where we are now is that the insurance programs, if you're insured, you need to be using your medical homes, going to public health services and using our valuable public health vaccines. I know that didn't go well with a lot of places, but you know, the state doesn't have the funds to vaccinate insured folks. So we've spent the last 2 to 3 years really working on our medical home, private networks, keeping insured kids out of public health, because every dose that all of our doses are counted for, and every dose that we give to an insured kid is a dose that a public kid can't get. They're not going to give us more funds because we're vaccinating insured kids, and the state just doesn't have the funds to be vaccinating folks who have medical homes and private insurance. So the provider sites, this is one of our major focus areas, is we need to get more providers into the VFC program. Right now we have about 3,400 provider sites in Texas. We'd like to see that well over 400 or 4,000. And a provider site is one practice, so it's not actual providers. I mean, we have about 5,000 or 6,000 providers in Texas, but this is an enrolled site within the VFC program, and it's broken out by regions. So financing, just want to hit on this for a quick sec. So our budget is huge in Texas. We're talking over $450 million a year that we spend on vaccines. And it continues to increase as the population in Texas grows and more vaccines are added to the schedule, and the price of the vaccines continue to change, 3 to 8% a year. So we have to manage $450 to $60 million a year in vaccines. And now the CDC is coming down, or we're coming down to the stage to make sure that this vaccine is going to the right people and it's being accounted for, and that the vaccines, when they're moved and transported, are a viable product that we can give to our children to make sure that they're covered. So we have the VFC program. Again, it's an entitlement program. If you leave today's session, if you leave and just say, hey, the VFC is an entitlement program, my practice needs to be built on making sure that those kids can get vaccinated. And whatever the other barriers that we have, programmatically or within a health department, those are the things we need to get by to make sure that none of those are keeping our children from being vaccinated. So we have the 317, which are also federal funds. And generally, we're using those, for, again, for those underinsured kids that we talked about, and for some of that goes into our adult safety net program, which we'll hit on in just a few minutes. The state really does a great job. Most states don't use general funds to support their immunization programs. So we use state funds from these different sources. We have an initiative to do adult immunizations, and I think we have the highest adult immunization budget in the country, over $8 million a year going to purchasing and providing adult vaccines. And the state of Texas does buy those adult vaccines off the CDC contract, so we do get them at a discount. So we have a great adult program. People look to us for our adult program, and we have a lot of sites. And we give a lot of vaccines through that, but we certainly can do a better job of that. We get funds through Medicare and Medicaid as well. And again, all these funds are pooled together to take care of those underinsured kids. And then we get about $25 to $30 million a year from CHIP. All right, 2014 TVFC program. We did a lot this year. We expanded the TVFC program into 2 section areas. There's so much that goes on around VFC. Big piece around education and operations, another big piece around vaccine management. And these are the different program areas that fall under there. You can look at this on our website as well. So we've really broken up the VFC program from one monster program into 2 separate areas, one working on policies, educations, the other one's working more on vaccine management, training and education. You know, we've done so much training and education now, expanding our provider networks, recruiting providers, the adult safety net program. It's all rolled into different program areas now, and both of our managers have been here, so if you've had a chance to meet either Kelly or Barbara, you know, certainly reach out to them if you have some additional questions. Reach out to your regional managers if you have different questions on the VFC program. These are other things. We've added so many resources to storage and handling, so many expanded our QA site visits where we're going into providers' offices, because you have to go in and check and make sure that everything that we're passing from the federal level down to the state level is being done. And again, to the same point, it's all being done to take care of the children. We need to make sure the vaccines are stored properly, transferred properly. We need to go into providers' offices. We need to go in there more. Make sure that their new folks that they hire are trained and understand how important it is to maintain the vaccine, the cold chain, the transportation of vaccine. That is our major focus area. We've done a lot with that. We have a lot of resources that come through the CDC. We've done a lot of resources at DSHS. If you have questions, again, we have resources and folks to go to about a new provider comes on board. They need to know how the program works, what they're getting into. But you know, it's not just the VFC vaccine. It's the private stock as well. So we're trying to really work to set up the vaccine storage and handling for the provider's office and not just for the VFC program. Storage and handling, eligibility screening, that's the second piece. You know, we've talked about, we can only ensure that we get these funds into Texas if we're screening and making sure that we're only vaccinating the eligible children. We can't be using our federal funds and our state funds, limited state funds, to vaccinate insured populations. And it's up to us to make sure that we screen them for eligibility. Those extra dollars are not there, and I think we've done a lot with that. And if you're a VFC provider, you've probably seen 20 or 30 different memos this year come out about different regulations and requirements and procedures. And that's all stuff that we have supposed to have been doing the whole time. Nothing's really changed. I mean, it's just more enhancement, education, and understanding about what we need to do to make sure, again, that our vaccines are appropriately stored and managed. We've launched a new VFC provider manual, which is great. That probably hasn't been updated in 3 or 4 years. That's now out there. It was sent out last month. We've had a satisfaction survey gone out, and we're also really doing additional focus on recruiting more additional sites for the ASN program. So in 2015, we're going to do provider re-enrollment. As you know, annual providers have to be re-enrolled in the program on an annual basis, so we need to get everybody enrolled this year within the first 3 months. Thankfully, we're trying to automate that this year where providers will be able to go online, get the providers enrolled in the system, so it won't have the major delays that we had this year as far as provider re-enrollment. The CDC trainings are required. They're not optional. We encourage everybody to take them, everybody within a practice. Even if you're not in a practice, you know, our partners we encourage to take to get a better understanding of how the program works. We've released a lot of guidance documents, a lot of support, education information out there for providers, marketing the program. We have now sent out or 9,000 different recruitment letters to providers, potential providers to join the VFC program. Because when the uninsured kids and these underinsured kids become insured, we need more provider sites for those folks to go to. And the 3,400 sites that we have now is insufficient. We need more sites. We can't be turning kids away because we don't have the resources to see them. Again, continue emphasis on training and eligibility. We want to conduct more site visits. We want to do unannounced site visits. And they're not punitive. They're all based on making sure the providers are educated and updated. And we all know that the staff within these providers' offices change 3 or 4 times a year. So we don't want to penalize the child because the staff overflow in a public setting or a private setting. So we need to be in there doing more unannounced visits. Immunization service level, our levels are good, but they're average. They're the same as everybody else. So we can do better, and we need to focus. HPV was, in the last talk, 50% is not good. 70% is not that great. We can do better, and we have great immunization rates when you start looking at school entry, but what happens in the 4 years until they're forced to have them is what we need to focus on. And it's same with adolescents. We need to make sure that they're not coming in, that they haven't seen a doctor in 4 or 5 years for immunizations. So those are things we need to work on in 2015. Additional resources, storage, and handling will be there. That's the first thing we're going to go and looking for. And that's what you guys should be out there looking for as well as private providers. Open the fridge every day and make sure it's all being stored adequately and properly. Vaccine choice options, we want to make providers happy and get them the vaccines that they want. Texas is a choice state. We get vaccines to them, the vaccines that we have, for whatever they want. Try to match up their private and public stock. And again, the ASN program. So I'm a little over time, so I'm going to kind of go through the safety net program really quick. So we've had an adult safety net program here probably since 1993-94 in Texas. It was an HIV, STD, hepatitis B program in the beginning. We've had a lot of expansions. It's really set up only for public entities right now. The aim is to increase immunizations for the uninsured adults in Texas. That's its major focus point. At the highlight of its days, when we had a lot of federal fundings through the ERA program, remember that was like the first major federal advancement program that went to vaccines. We had another $12 or $13 million added to the adult program. It's kind of gone up and down on what we're able to do, but now that the Texas legislature has committed $8 million a year to the adult safety net program, it's a huge commitment from the state to add to make sure that we can continue and advance this program. So we have a lot of sites. We have a lot of sites that don't give shots. So we need to really work on that this year, and we need to look at maybe expanding on who we're recruiting as far as the ASN program. This is the formulary. Almost all the vaccines are on it. There's talk of expanding to the couple that come on and off of it, but these are generally the vaccines that we need to make sure that our uninsured population gets. We've had meningococcal and zoster we've looked at as well. Sometimes we're able to add those for a limited amount of time, but we're committed to financing this program and keeping it going. But again, we need providers to go out there and access it and get folks in for this program. These are the different sites that are available that can receive it. We have it on our website. Folks can go online and find out where the closest ASN site is for them to get vaccines. And then the policies, we were able to increase the admin fees. I understand that a lot of uninsured may not have funds to pay for it, but certainly that's not a reason to turn them away. It's good public health to offer vaccines to uninsured adults, and that's what we all need to commit to do. So remember, at the end of the day, when you leave the sessions and the doors open, remember that the entitlement program and the VFC program goes to the child. And thank you very much.
All right, good morning. I'm always entertained when I go after work because I'm watching we had a lot of slides last night and knew it was going to be difficult to get through all of them. So I'm going to go through these a little bit quickly, and again, they are going to be posted so you can look at them later, and we'll try to save some time because I know there probably are a lot of questions. So we just wanted to give you an overview of the new MTRAC 2 and kind of give you like a little bit of background on why we're going in the direction we're going and what we hope that you can gain out of the system when it does launch. So this is just a really quick snapshot of what the old school paradigm was for public health when it came to registries, and it really was just kind of like a one-way repository. We expected that clinicians would send us their data, and then basically it would sit somewhere in a black hole, and they didn't really expect much out of it. And the new paradigm for public health really shows that it's bidirectional. So we know that providers need to get something out of it in order for them to really be incentivized to use it. And public health needs actually more out of it as well. So what you can see is that there is an expectation in the future that we can actually respond to queries, that providers can query us, that we can provide better immunization records and decision support back to providers. And what you see at the bottom is that the inventory and ordering has been added, because over the years they've noticed that the best practices across the country have shown that when you do everything related to your vaccine inventory, your vaccines all in one place, you actually have more robust systems and more robust practices. So what that means for us in Texas is that we're taking two pretty disparate systems and we're combining them into one. So you're probably familiar with MTRAC, and if you are in the TVFC program, then you're familiar with EV, our electronic vaccine inventory system. And those two systems we refer to now as our legacy systems, which will be retired, and the data in those systems will be moved into MTRAC 2. Was that new? Was that news? So we just wanted to show you a little bit of what we manage at the state level to give you an understanding of the scale of work that is undertaken in Texas and why it makes sense for us to retire these older systems. Well, Evie's not that old, but we're still retiring it. So this shows you an increase in the immunization records that we have in MTRAC, and I think as of this week, I was asking, and I said that we're over 130 million records that are sitting in MTRAC. So oftentimes I hear people say, there's not a lot of data in MTRAC, and that's just not true. There is a lot of data in MTRAC. And a lot of this really was incentivized through meaningful use. So as providers were getting more electronic medical record systems, they were able to send data electronically. And we, in Texas, made a lot of modifications to MTRAC to be able to get that data and actually, meet those requirements. So you can see that there's definitely a trend of more and more immunization records. And the same sort of trend can be seen for our user sites. So we have more providers, or more sites out there in the state that are actually using MTRAC and sending data to MTRAC. So Mark just showed you this. And again, it's really relevant to the whole MTRAC too, because when you're talking about trying to manage nearly $500 million worth of vaccines, and we're talking 30,000 orders, it's really important that we have a robust system that we can't afford for it to go down. We can't afford for, we have a very narrow margin for error or for a system to actually go down. So I won't spend a lot of time reading this to you. Really the point of this slide is just to say that whatever functionality we have in our current systems, we're going to maintain. We're really trying to just improve upon what we have to offer to our providers. And we really are excited about all the new enhancements and the new functionality that's out there. If you are in the TVFC program, then you probably remember the little short period of time where you were really concerned about whether or not you had to separate VFC from CHIP from your underinsured. And that was a bit of a fiasco. And what happened is, we were really trying to meet the CDC's requirements for maintaining our vaccines for the different eligibility groups. And then what we did was we asked them for if we could, at a state, when we launch this new system, then we can actually maintain that on the back end so providers don't have to be burdened with that. So we were able to have blended inventory again, where you could have all of your public inventory versus your private inventory, but your public could all be combined again because we said we're going to go with a system that actually can do dose level eligibility within the system. So that's the big reason why all those stickers went away. One of the really exciting improvements that you're also going to see is that you'll have a single sign-in. And so right now, if you're in the TVFC program, everybody shares a login, which is not secure. So, it could be secure for your site, but it's not the best practice to have one login that everybody shares. So going forward, it's actually a user-based system. And so you as a user will have your own personal sign-in, and you'll be affiliated with whatever organizations you might work at, even if it's multiple organizations. And we're really excited about our streamlined registration process. So again, in the TVFC program, it's like an 8-page enrollment process that you go through, and we know it's not fun, but it's actually required. In fact, we are required to ask the questions exactly word for word the way that they are on the CDC form. We don't have flexibility on that, but we are going to be the first state within the WEIR consortium that's going to actually have a fully integrated online enrollment and registration process. So we're very excited about this. And I just put this in for reference. So WEIR is the Wisconsin Immunization Registry. Wisconsin launched a registry back in 1999, and then what they basically did is just said, this is going to be open source. We're going to offer it up to any state that wants to be a part of it. But if you're going to be a part of it, then you have to sign a legal agreement that says that any enhancements you make, you will actually share with any other state that's in the consortium. So what's really cool about it is that you have small states like Hawaii, and then you have big states like Texas. I mean, you've got states with, very big budgets, and you have states with very small budgets. Oftentimes people with very small budgets are very creative because they don't have a lot of money. But either way, all of these states get to really collaborate together, and the consortium is really active. What it shows is that there are 2 vendors at the time that support these different WEIR states. And what I think is exciting about this is that California, I couldn't modify this slide, but actually they're not pending award anymore. They have been awarded, and they are starting their work, and they will be they're working through HP as well. So our vendor is HP, Hewlett-Packard. California's vendor is also going to be Hewlett-Packard. And what's cool about that is that California has 38 million people. Texas has 26 million people. Between the 2 states, we move about 25% of the vaccine inventory in the nation. So I think that just the collaboration of having states that are really big and move a lot of inventory out there, I think you'll see, hopefully we will build in some really cool improvements as we keep going. I'm not going to read this to you as well, just to say that we expect a lot of our immunization information systems, and we touched on that earlier. So this is no longer a world where you can just send information and it just sits in a box. I mean, there is a lot that these information systems are really kind of expected to do, and it's important for us to have a platform where we can keep improving it and we can keep making some sorts of adjustments and enhancements as we move along. So this is specific to HP because they are our vendor, but again, there were other states that were using STC. I put this in here for a couple different reasons. First is to show that these are all the states that HP supports on the registries, the IISs. And what's nice is that you can see that the system that we're getting is very scalable, and it's also capable of handling really large volumes. The other thing that I wanted to just point out is that if you look at the number of patients or the number of clients that we have in our system, and then look at the number of records we have in our system, it doesn't necessarily make sense in comparison to a lot of other states. So I bring this up because, if you've ever worked with new complicated, complex systems that launch, there's always going to be a period of adjustment. I think we are going to see our number of records probably go down as we start really seeing some deduplication, as we really try to clean up our data. We do have a lot of records in the system, and within the current context of the system that we have, we're doing the best we can. But I think that as we move forward, we will likely see a decrease in the number of records in there. So these are I have a few different screenshots. We're really excited that we actually had version 1 of our code. We received it into our test environment at the end of August. So it's really exciting to finally see the stuff that you're working on, actually sitting on a screen. So I just wanted to show you a few different shots so that you're a little bit more familiar with it when it does launch out in your practice. This is just a login screen, and it is a login screen that everybody will see. The blue bar on the left is what shrinks and grows based on the rights and role that you actually have. So if you don't do inventory with this, you will not see any of the inventory options. If you are a school provider, you will see a very limited menu. If you are a state regional office, you will see a much more lengthy list of options on the side. So it's going to shrink and grow. And it's a quick snapshot to show you if you're running low on inventory, or if you have if you have inventory that's expiring. So and then there are menus at the top that will just stay with you so that you can kind of continue. As you navigate through different screens, you'll know which role you're in based on the org that you picked. There are a couple different screens that are split here because this is long, but I just wanted to show you what a client screen is going to look like now. It will actually have a lot more data in it. It will let you know if it's a historical record versus one that you actually entered. You'll only be able to edit records that you personally own and entered. And at the bottom of the screen, it'll have a highlighted recommended vaccines, so recommended dates, past due dates, so that you actually can keep up with the kid. I'll try to go quickly through these. And this I wanted to show because primarily for, let's see if I remember which one's the highlighter. This is very new. So when we were just talking about dose level accountability, vaccine eligibility right there is now required. So when we receive files from providers through data exchange, or when a provider goes in and tries to enter a shot record, they will have to tell us why that kid received, what made them eligible for that dose. Were they on Medicaid? Were they uninsured? Because you know that that the children who are in the VFC program, eligible for the VFC program, tend to go on and off of different eligibilities. They can be uninsured to Medicaid, back to uninsured to CHIP. I mean, it varies. So we need it at the dose level. And oftentimes now the data that we get is at the demographic level, which isn't really useful. So this is also very cool. You can use this system and all of the inventory management to do your private inventory. And we presented all of this information to the Texas Pediatric Society's office managers, and I think they were excited about that because really this is not about just managing the inventory that we send out to you. It's about managing your entire practice. So they seem to think that this was actually very simple and really easy, and that it would be helpful to them to actually be able to put in all of your inventory. And that way, when you're decrementing inventory, you can select if it's your private inventory or your state supplied. And you can also, in the new system, set your own personal reminders. So if you want to be reminded 60 days out for large practices, or if you really don't need a reminder at 30 days and you want to know when you're down to 5 doses, you can actually select that and personalize it, and even personalize it based on your state or private inventory. And then you just heard Jill talk about how reminder recall is one of the most effective ways of getting kids in for HPV vaccines. So the reminder recall features in this new system are far more robust than what we have in the current system. So hopefully that will be useful for all of our providers. This just shows you like a quick summary of what comes out of your reminder recall process as you make the different selections. And what we really like about it is that it's only going to actually list for you clients with a valid address. So it's going to show you how many kids actually met the criteria that you selected, and then it's going to say only 20 have a valid address. And then what's even better is down here on the client query listing, providers know their kids. They oftentimes really do know them better, so they can actually select that and look at the list before they go to printing. So it's an effort to kind of save money and make things a little bit more useful. And this is just benchmarking reports. You heard Brock talk yesterday morning about how we really need to do a lot more of our own assessments, and COCASA eventually is going to be going away. So states are already trying to figure out how to build in a lot of those assessment reports into their IISs. And so we will have some reports that are already available so that providers can actually look at their data and see where they're at and how they compare. So this is our dose accounting in EV, and I just threw this in so that you could just see for reference based on what we just showed you. Right now, you order vaccines, and then you go in and you basically tell us, I had 30 vaccines and I administered 30. And we don't know. That's the most information we have is the number that you gave us. And that's not acceptable anymore in the world as we go forward. This is the way that you can actually do dose accountability, how you can actually see your dose accountability in the new system. So you can select your dates and all of these different criteria, and then it will actually tell you for each dose what happened to that dose. So this is dose level accountability at a much more useful level. Okay, those were all the slides. We just put in our call to action in support of the whole call to action here at the conference, that we, as Mark said, we're always encouraging providers to join and participate in the TVFC program. And we encourage you to participate in MTRAC and in the new system in MTRAC 2. Don't wait until it launches. You can get started using the system now. And keep client records updated in MTrack. If you use an EMR, then it's even easier. You know, at this point, 76% of the records we receive come through data exchange. People aren't logging into MTrack and actually entering it. So the vast majority of our data is coming through data exchange. I probably should have put it up as well, but you know, we do not have a lot of adult records, even though it's a lifetime registry. I might be in it. There aren't very many people in it. It is about 1.5% of the adult population actually is in MTrack right now. So of the 7.5 million that you saw up there of our clients, we have about 355,000 adults. So very, very few adults are actually in MTrack, and we need to find a way to make sure that people understand the importance of maintaining that record, because those yellow shot records get lost. Providers change, they move. It's important to have one consolidated record. And that's it.